I've been given this task of talking about interventional cardiology, historical aspects of it, what was the past and what is the present and what the future holds for most of us. It is nice to grow with the cardiology since I've been practicing from 1970s. So when we passed out from CMC, at that point of time, you'll be surprised that echocardiography was non-existent. And at the most, we have had only M-mode echocardiography. And we spend most of the time in trying to see the X-rays, in trying to interpret the ECGs, and in trying to examine the patient, most important of all, to get as much of clinical data as possible. As things moved on, interventions came into existence, and then the whole field of cardiology had changed from basically a clinical cardiology to basically an instrumental cardiology. So this is what it is. It started very early, but I think intervention need not necessarily be therapeutic. It can be diagnostic also. We are changing now from interventions of stenting to interventions of structural heart disease, interventions of aortic diseases. All this started only with the first man to do the cardiac catheterization. Mind you, he was a surgical resident. He was Werner Frostman. He tried to pass a catheter into the heart, not for diagnosis, not for evaluating the pressures, but he was trying to inject a drug directly into the heart. That was his aim. And he used a ureteric catheter for passing it into his own antecubital vein, and he could manage with the left hand all the way to the right atrium. And for that act, he was thrown out of the hospital. And he left the medicine and then started practicing from the remote place until he got his Nobel Prize, much years later. And then he remarked, this recognition has come too late for him. Be that as it may, when he did it, the procedure, he was 24 years old and resident in training in surgical department. Then there were further people like James Warren and Henry Zimmerman who were trying to use a cardiac catheter for diagnosis, and basically it was a right heart cath initially. It was Zimmerman who first introduced the left heart catheterization. And surprisingly, a catheter was inserted into the radial artery, not into the brachial artery, not into the femoral artery. So the first case of a left heart cath was done through the right radial, from the right radial. And you'll be surprised that the catheter was lubricated with olive oil before you put into the artery. This is how we started. Then came the accidental discovery of a selective coronary angiography. Mason Sones was a pediatric cardiologist who was trying to do a aortic root injection in a child, and then he did inject almost 25 ml of contrast into the aortic root. What he thought was aortic root, suddenly found after injection the whole dye has gone into the right coronary artery. Injecting 30 ml of dye into a right coronary artery under pressure promptly resulted in cardiac arrest. Took some time for them to recover from the shock, but anyway, they did resuscitate the child. So an accidental entry into the coronary artery, he thought we can make an entry with a purposeful catheter, and then the selective coronary angiography started. And believe me, Mason Sones was a pediatric cardiologist at Cleveland Clinic. Then came the radiologist, Melvin P. Judkins, who developed pre-shaped catheters, and then he commented that the catheter would go unless thwarted by the operator. The catheter knows where to go unless thwarted by the operator. That made coronary angiography very easy. So everybody started doing coronary angiography. And from the historical point of view, you'll be surprised that no adult cardiologist has really contributed to the future of the cardiology from 1960s onwards. It was first the Seldinger who was a radiologist, then Mason Sones was a pediatric cardiologist, Melvin P. Judkins was a radiologist. And it was Melvin Judkins and Mason Sones who formed the Society of Cardiovascular Angiography and Interventions, of which many will take a pride in being a fellow of that organization now. But it was formed much earlier. And it was formed as Society of Cardiovascular Angiography and Interventions, not Society of Cardiology. Then came his daughter, who was again a radiologist, and then he found that after doing a procedure of angiography, an artery that was narrowed, you can see it on the diagram on the first one. After the catheter was removed, the artery looked much bigger. So that's how the idea came that you can do a transluminal angioplasty. So the angioplasty era really started in 1977 with Andreas Grundzig. He was working in Germany, he was working in Zurich. And then when he first presented the paper, when he sent the paper to the American Heart Association, it was not accepted for oral presentation. It was given as a poster presentation. That was the importance given to that paper. Only to be recalled to that country by Dr. Willis Hurst to come and join the Department of Cardiology and establish the Department of Interventional Cardiology. And for him, he was made an exception not to appear for the entrance examination of the foreign medical graduates. Until now, I think he is the only second or third person to be exempted of going through the examination before you are enrolled into the system of medicine practice. Now it is almost a fairy tale story from September 14, 1977. Then he did on a patient called Dolph Bachmann, 38-year-old man, almost the same age as Andreas Grundzig. And then the angiogram is there for you to see. So the proximal LAD, and the angiogram was done 10 years down the line, which did show that plain old balloon angioplasty, the result was quite acceptable even at the end of 10 years. That was after the first angioplasty and 10 years down the line before the era of the stenting. It is very surprising that all these people who have contributed to the cardiology, growth of cardiology, all of them died in the same year, 1985. Starting with Mason Sones, who died in February, then followed by Judkins, followed by Charles Daughter, and Andreas Grundzig in a plane crash. So all these people died, one after the other in the same year. That's why it's called a dark year of interventional cardiology. After the advent of balloon angioplasty by the Grundzig, I'm not sure how many of you have really seen the Grundzig balloon catheter. It did not have a central lumen, and it only had a tailpiece, a front piece of about 2 centimeters or 3 centimeters with a floppy wire. There was no way you could control the floppy wire. You have to adjust you have to handle only the catheter for it to manipulate itself through the lesion into the area of desire. Then came Simpson and Roberts balloon, SR balloon, wherein for the first time that there was a central lumen into the catheter and through which we could pass a wire and then manipulate the wire. Then came all the additions between 1988 and 1993, that is the next 5 years. Laser angioplasty came and then disappeared because it was causing a lot of complications. Atherectomy came and persisted. Directional, rotational, and extractional atherectomies. All of them did contribute for better outcome, but they were associated with frequent complications and like acute closures, dissections, perforations. And because of many instruments being used, it was quite costly as well. And you'll be surprised that plain old balloon angioplasty has resulted in a restenosis rate of 40%. Then came the era of stent, the Palmers and Schatz, and then they did, after 2 trials of stress trial and Benny stent trial, it was a bare metal stent. They did show that it does work, at least it prevents acute complications from that. And in 1994, the first bare metal stent was approved, Palmer-Schatz stent. Then came an improvement on this bare metal stent, followed by the so-called drug-eluting stents. In between, we had intravascular brachytherapy to control the neo-intimal hyperplasia, including some other studies from India. I think Dr. M.J. Gandhi did the study with using beta radiation over the impregnated into the bare metal stent, courtesy nuclear fuel complex of Hyderabad. Then came the era of the drug-eluting stents, and where there is, on the stent there was a drug through a carrier called polymer, which was delivering the drug sequentially over a period of 6 months to 2 years. And in 2003, the first drug-eluting stent, that is the Cypher, came into existence, followed soon after by the Boston Scientific, wherein there was paclitaxel eluting stent was available. Then came the various modifications in the stent platform, first generation to second generation, wherein the studs were thinner, fewer, and more radial strength, and less polymer and less drug also. Consequently, it resulted in better outcomes in the long run of the vessels in which it was implanted. So there were 10 stud design, reduced polymer layer, and use of a novel drug, especially sirolimus group of drugs, that did give a lot of long-term results, and the restenosis rate fell to single digits. From 40%, it became single digits, that is 10% or 9%. Then following that, we had absorbable stent, Absorb GT1. But then during all this time, there was development of intravascular imaging, how these stents were deployed and what is the mechanism of restenosis after balloon angioplasty, mechanism of restenosis after bare metal stent, and mechanism of restenosis after drug-eluting stents. So there was different mechanisms, but intravascular imaging is now the order of the day, especially in complicated angioplasties and delivery of the stents. So my plea to the young cardiologists of this society is, I think instead of all of you going into an intervention, some of you should go to imaging, cardiac imaging as a specialty. And it does require a lot of commitment, and probably we are prepared and better equipped to interpret the data and to know the utility of the data and shortcomings of the data. It is both CT, cardiac MR, and nuclear imaging, not to forget about intravascular imaging. There's a lot of potential, especially now there is a new specialist has arrived and is labeled as interventional echocardiographer. That has become a specialty now, and people who are interested in echocardiography can continue their career as interventional echocardiographers. Now, because of the imaging, now I think in the morning you have heard the talk on by John Christopher on FFR by CT. It is still in evolution, and then probably very soon we are going to have FFR CT even in the city. Now, this is so far up to 2012, 14, 16. Now we are coming to a stage wherein we have almost static in numbers of angioplasties and stentings. So the attention has diverted to other structural heart diseases, especially valvular heart disease. And it started off with Alan Krieger doing the first catheter-based aortic valve replacement in 2002. It has matured to the extent now that people are thinking of doing transcatheter aortic valve replacement instead of a surgical aortic valve replacement, from surgery to catheter-based. Now the current thinking is all patients with aortic valve disease should have TAVI, and only high risk for TAVI should go for surgery. This is the current thinking now. The TAVI has been approved by the FDA in 2014, but now the future of TAVI is improvements in the delivery system. But this is what is predicted now. TAVI for everyone and surgical valve replacement only for high-risk TAVI patients. This is going to be the order of the day. So we need a good imagiologist who can interpret the data on the aorta and coronary arteries, calcifications, entry site, the size and calcification of the iliac vessels. There are a lot of things to be done before the patient is put for TAVI. But most of it is dependent upon the imaging. So interventional cardiology in 2018, minimally invasive is the probably right thing. And basically now we are moving from coronary angioplasty to valvular heart diseases. It is now almost an established one for aortic valve. We are going to have more talk on mitral valve, pulmonary valve replacement by catheter. Succeeding speakers are there who are going to enlighten on that. So in interventional cardiology, change is going to take place from coronary to the valvular heart. I'll take another 5 minutes. And what is constant in life, and this is again the same thing, this catheter-based intervention for structural heart disease now, apart from other valvular heart disease, there is even catheter-based treatment for paravalvular leaks. We have done in our hospital about 2 or 3 cases of mitral paravalvular regurgitation successfully. Though some failures have been there, but we have made a beginning. And one of us are taking a lot of interest in paravalvular regurgitations. Catheter-based LV assist devices, probably shorter. LA appendage closure devices through the transeptal route has become order of the day in people with atrial fibrillation with high bleeding risk and where there is a high risk for ischemic embolic complications. Finally, last but not the least, creation of ASD by a device, especially in patients with pulmonary arterial hypertension with recurrent syncope. So you are going to create an ASD in a patient with pulmonary arterial hypertension so that syncope is abolished, but at the cost of arterial desaturation. So transcatheter mitral valve replacement is still in its infancy, but we still have to improve on it. There are some what we call micro pumps are available, but everything is in pipeline, not yet approved by the FDA, not yet approved by the professional organizations. And actually there are some percutaneous ventricular restoration devices by using a parachute type of device wherein you can seal off the aneurysm without surgery by across the transcatheter delivery into the LV apex. What to expect? Probably robotic PCI and robotic surgeries may not be out of time. Very soon we are going to have one. So change is constant and we have to plan for it, and then without taking much of the time. The point here is not to predict the future, but to prepare for it and to shape for it. And if you want to change, you should be the change and not expect others to change. So if we have to move forward as a cardiologist, we should be prepared to have a good imagiologist along with us. It should be a team consisting of an interventional cardiologist, a good cardiology imagiologist, and importantly, a good anesthesiologist, and more importantly, a good non-interventional clinical cardiologist who can prevent overperformance of the devices. Thank you, ladies and gentlemen, for your attention.